Hello. You can call me Paul, but you can also call me Steven. That's okay too. That's okay. I've grown up with two first names my whole life, so I'm used to it. But it's Paul with two L's, and the first L is silent. All right. So I'm happy to be here today to talk about therapy approaches to coordinated care for clients with dementia. And by the way, thank you for that nice introduction. I appreciate that. So I'm going to skip some small talk about myself because you've already heard enough about me and go right into the presentation. So according to the World Health Organization, there's around 60 million people worldwide who are living with dementia and over 10 million new cases each year. Today, we will discuss the therapeutic interventions that are available to help both individuals and care partners adapt and live with the changes due to dementia. These interventions can improve a person's quality of life and independence. We will provide an overview of how rehabilitation services can provide evidence-based interventions in a coordinated approach with the persons living with dementia, care partners, and the interdisciplinary team. So for our agenda today, we're going to talk about the role of therapy in treating dementia, assessment of cognition in patients with dementia, intervention approaches, and then we will have a period at the end for questions. So here's a picture from 1917, and this is some documentation, which is kind of, I really have to say, with one of the sponsors being today Butler Hospital. Butler Hospital was a very integral part in the moral treatment era of mental health and was one of the first places where we can track occupational therapy as a practice. So it's kind of awesome. And actually some of the slides you might see actually might have been pictures taken at Butler Hospital from their nursing department. So occupational therapy is an offshoot of the nursing department. The use of occupational therapy tasks or everyday activities, now known as activities of daily living or ADLs, and the arts and crafts was used in the 1800s for treating individuals in asylums to address severe mental health conditions. OT pulled many different places to develop the most beneficial way to functionally help clients. This involved aspects of physical therapy, nursing care, social work, psychiatry, orthopedics, and more. Immediately, occupational therapy stood out as a unique and holistic practice. The use of person-centered care began with occupational therapy. The first occupational therapy education program began in 1915. Today, OT requires at least a master's degree and a doctorate of occupational therapy for new grads. That includes a minimum of 6 months of clinical internships, including mental health and physical rehabilitation. OTs are also required to pass a national registration examination and must maintain credentialing every 3 years, and also must have a state license to practice in the states in which they provide treatments. Occupational therapists help people across their entire lifespan, from premature infants to hospice care, doing the things they want or need to do through the therapeutic use of everyday activities. Another therapy approach is speech-language pathology. A speech-language pathologist is an expert in speech, language, cognition, and swallowing. They study and treat people of all ages with conditions that impair speech, language, voice fluency, swallowing, cognitive communication disorders, such that might be associated with dementia. Speech-language pathology had its roots in the elocution in 18th century England. Speech-language pathology began to get recognition when the American Academy of Speech Correction was formed in 1925 by an association of people working in the area of, I love this, rhetoric, debate, and theater. I just think that's so awesome. These professionals became more interested in the science of speech as World War II soldiers were returning home with brain injuries. In the 1940s and the 50s, an increased focus on brain processing or thinking abilities continued the scientific evolution of the professional practice. This continued when between 1965 and 1975, advancements in the study of linguistics supported the distinction of speech disorders and language disorders as different. In 1978, the American Speech, Language, and Hearing Association was born and remains the governing body of the profession to this day. In order to practice as a speech-language pathologist, a master's degree and postgraduate clinical fellowship is required. Regulatory requirements include state licensure and certification at the national level through the American Speech and Language Hearing Association. Physical therapy. It was the year 435 BC when Hippocrates began advocating the use of massage, hydrotherapy, and the manual therapy techniques to treat his patients. This is believed to have been the first origins of what would become today physical therapy. Modern physical therapy began to take shape in the 1800s, which evolved around two major historical events: the polio epidemics from the 1800s through the 1950s, and the effects of the ravages of several wars. The first training of the Reconstruction aides were responsible for caring for those individuals wounded in World War I. Poliomyelitis raged throughout the country in the 1920s and 30s. Wounded soldiers and also children with disabilities soon received physical therapy treatments, leading to the formal incorporation of PT as healthcare practice in 1924. Today, PTs help their patients manage chronic conditions, overcome debilitating pain, and rehabilitate from illness or injury. PTs keep us moving. Physical therapists new graduates are required to have a doctorate in physical therapy, which includes a 1 year of clinical internship and requires a national certification and state licensure. So what is the role of these approaches? Occupational therapists, speech-language pathologists, and physical therapists play an important role in the treatment of patients with dementia in coordination with the interdisciplinary team. This includes the person living with dementia, their care partners, and family members, doctors, nurses, neuropsychologists and neuropsychiatrists, CNAs and home health aides, social workers, and other patient professionals like dietary staff, behavior specialists, psychologists, and recreation activity staff. The goal of treatment is to maintain quality of life of a person with dementia for as long as possible. OTs assess and develop patient-centered plans of care with goals to optimize function, independence, and participation in ADLs and instrumental ADLs. They also work closely with care partners to adapt the environment and their responses to the behavioral response expressed through pain, frustration, depression, and unmet needs of the person living with dementia. Speech-language pathologists help a person living with dementia maintain appropriate levels of independence throughout the disease progression, specifically targeting attention, memory, problem-solving skills, communication, and other cognitive linguistics skills. A speech-language pathologist may also assist an individual with dementia in eating and swallowing safely. PTs as the member of the interdisciplinary team, concentrate on mobility, strength, and endurance, balance, and fall prevention. Today, for this presentation, we are going to focus on the role of OT and speech-language pathology because CareLink was recently awarded a grant bringing evidence-based programs to the community that are specifically designed and implemented by these two disciplines. But please know that physical therapy also plays an important role in treating people living with dementia and must be included in the team of care providers needed for health and welfare of both the person living with dementia and their care partners. It was very important that I talked about PT. I actually married a physical therapist, so if I don't mention and uplift physical therapy, that would not go over well. So, the OT assessment. So when occupational therapists work with someone, the purpose of the assessment is to get some information. So we are assessing range of motion, strength, safety awareness, functional mobility, sequencing, orientation, posture, muscle tone, sensory processing, motor planning, and cognition. Ooh. That's okay. I could probably shoot from the hip if you turn the lights off. We determine the level and type of assistance needed to safely perform ADLs and instrumental or IADLs. ADLs, activities of daily living, are the things we do every day. Grooming, washing, dressing, toileting, things that we don't do that we kind of do automatically almost. IADLs or instrumental ADLs are activities that we probably do every day but require a little bit more thought and planning. They're things like medication management, going to work if that's the stage of life you're in, leisure activities, managing your finances, planning and preparing meals are all examples of instrumental ADLs. The assessment also helps determine or stage the individual's level of cognition function. And the assessment, the most important outcome, in all disciplines that we talk about today, have a patient-centered care plan to address their needs. So we really end up after the assessment with a kind of a specialized plan of care that's just for that individual. And that really drives the OT sessions and the interventions. Speech, language, and pathology assessments measures speech and language skills as they relate to verbal, auditory, and written communication and the integration with cognitive function. Identifies the presence of the level of cognitive linguistics impairment through informal and standardized assessments. Identifies the strengths and deficit areas, and also develops a centered treatment approach to address the assessment findings. And I said I wasn't going to talk about PT anymore, but I will talk about a physical therapy assessment. The purpose of their assessments is to assess range of motion, strength, and endurance, assess gait, mobility, and balance, helps determine the type of assistant devices needed to safely move within their environment. They also help identify safety issues, and the assessment also helps create a patient, person-centered care plan to address their needs. So in this slide, I'm going to be talking about standard cognitive assessments. Standard assessment tools are exactly that. They're tools that a therapist will use to determine a baseline level of function. It helps identify a patient's specific strengths and weaknesses. It provides a standardized rating level of cognition. So it'll help us we'll be able to tell someone if they're mild or moderate or severe, would be an example. And it helps drive a patient-centered treatment plan. The importance of the patient-centered treatment plan is that you really want it to fit the person so that you can build success into our sessions. If we don't have a patient-centered approach, then it's not going to have any meaning or really impact on that person. So in this slide there, you may have seen some of these are examples of tasks that a person might have to do. They might have to draw a clock, or they might have to do a lacing task, which can tell a therapist, providing the standardized assessment, a lot of information of how they're thinking. Here's a list of a lot of cognitive assessments. I won't get into the details of each, but these are just some common ones that an occupational therapist or a speech language pathologist may use. And again, these are just some examples. There's many, many more, and it's really at the discretion of the evaluating therapist. They pick and choose what they think the cognitive assessments they need for this particular client or person, and they'll provide the standardized test to get the information they need. Now, the intervention approaches. There's a lot of benefits to the approaches. So promotion of health and well-being, I like to kind of put that in the context of spirit, body, mind. Really kind of embodies occupational therapy. So in occupational therapy, promoting that health really kind of looks at that kind of triangle. And that also happens to be the primary symbol at Springfield College, if there are any Springfield College alum. Springfield College emblem is an upside-down triangle, and they embrace the kind of spirit, body, mind. Adapting to changes. So we want to restore performance by adapting the way a person might do their activities of daily living or their instrumental ADLs. This might include improving how their body moves, improving their range of motion, or improving their strength. Or it might be adapting how they approach a problem or a task, and maybe helping them learn to use visual cues. Modification, adapting and compensation to provide a change to the environment. So we might look at the environment and make recommendations on and how to approach that environment and how to interact in it. And then last and not least, the approaches often focus on education, and that can occur with the individual with dementia, the care partner, and the interdisciplinary team. Education regarding specific difficulties and specific strategies to compensate. So again, we're doing a patient-centered approach. We're making changes to the environment, looking at function and safety. We're looking at a person's process of patterns and routines and trying to build on those. And most importantly with our interventions is purpose. Purpose really is what drives the motivation of the person participating in the caregivers. So activities of daily living. A therapy session with a person might actually involve doing that activity with the person. Out in the field practicing, calling a client to make a patient or a person to make an appointment to come and see them, they'll say, "Oh, don't come out in the morning, I'm getting ready. Come afterwards." And I'm like, "No, can I come and kind of see how that process goes? I don't have to be right with you, but can I take a look and see what the process is like and where you're at?" Because that's part of our assessment. And sometimes that throws people off, but it's really important. Activities of daily living often is a great window into how a person's function, and it also provides, with a therapist doing an activity of daily living with a person, it helps us build a rapport with them, and it helps us begin that education and that training process in making adaptations and making modifications. Cognitive stimulation is another important part of our approach, and that's often wrapped into not just the activities of daily living in the instrumental ADLs or IADLs, but also in the exercises that we do with people. We're always looking for ways to incorporate cognitive stim into our approaches, but we also have very specific tasks that we'll do or interventions that we'll do that'll just focus on cognitive stimulation. And you might hear therapists in all of these disciplines say use it or lose it. So the cognitive stimulation is really important part of our approach in occupational therapy. And then probably the most common thing that people see in occupational therapy intervention is therapeutic exercise and activities. You could do a whole lecture on the benefits of exercise that people get. It's not just, doesn't help the body move better and function more, but there's also mental health benefits. It helps you produce natural antidepressants if you exercise regularly. Also, studies have shown just people who exercise also helps improve cognition. And there's studies looking into that and how exercise changes the physiological function of a body and how that contributes to improved cognition. And then another key part of occupational therapy intervention is the use of purposeful activities for function and independence. One of the mottos for occupational therapy is, we promote healing through the use of our hands. Now I'm going to turn it over. Laurie's going to finish up our presentation and talk about speech.
Thank you.
You're welcome. Get my water.
All righty. Good afternoon. Thank you for being here. So thank you, Stephen, for all of that information. And one of the things that I want to say is that it's so important that you understand the history and the techniques that we utilize, because you can actually treat dementia. We can't cure the diseases, but we can treat the symptoms and the difficulties that people are having. And that's where these interventions come in. So with speech therapy particularly, they focus in on individual strengths and always trying to build on successes, because those successes help encourage someone, build their self-esteem, and it really helps them to continue to try and be involved in their activities. One of the techniques that they use in speech is called space retrieval. As an OT, I also use it. And typically what we do is we take an essential pattern that they need to do, such as sitting down. And we want to make sure that they're reaching for the arms of the chairs before they sit. So we go into a pattern where we say, back up and reach. And they say it over and over again as we do the pattern, and it becomes a habit. So we're really working into the safety into their therapy sessions. Another way is, as Stephen mentioned, modifying the environment. I love using pictures. Our pictures that we're using for the bathroom directions are one of those examples of taking a picture and placing it on a drawer where the socks are or where the t-shirt is, so that the person knows where the items are. Okay, and tapping into other external memory aids, such as calendars and clocks that help. I had this wonderful tool that worked with this person where every day they went out with their loved one. It's like, where are we going? And she would tell them, and then 5 minutes later, well, where are we going? Well, 5 minutes later. So I said, get a notepad. And on that notepad, write down where you're going and what time you're going to be there. And you can start out with, we're going to Dr. So-and-so at 12 o'clock, and point to it, and hand them the pad. And then they say, where are we going? Let's look at your pad. Where are we going? Just showing your hand will signal them to go to the pad. And then they get to the point where they can remind themselves, okay? And swallowing is so critical with people with dementia. Research shows that about 50% of those individuals with dementia will develop some form of a swallowing disorder that can result in pneumonia. So it's really important that we tap into these resources of speech-language pathologists to really look at people's swallowing patterns. There are exercises that can be done, there are tools that can be used, and great research out of Boston University that shows that using a red plate can actually increase someone's appetite by 25%. So, if you want to lose weight, don't use a red plate. Okay? And then interventions with physical therapy, we mentioned before, we're looking at range of motion and strength, endurance and balance. Home safety is critical, but also wellness. We know through the research that's been done that exercise, diet, sleep, social and intellectual stimulation, all are important to our brain function. And tapping into our wellness, looking at aerobic activities, Tai Chi and yoga, and some samples here of physical therapy for dementia care. Always involving the care partners and the other people that are involved in their care and providing education. So this morning I talked a little bit about the evidence-based programs. An evidence-based program is a program that's been researched and studied and then also peer-reviewed to make sure that it does what it says it does, okay? And I'm really excited that we're going to be able to bring you some of these evidence-based programs to Rhode Island. But let's take a look at a couple of them. There's one particular that I really hope that you do some research on. It's called the Montessori approach to dementia care. And it's all based on the work of Dr. Maria Montessori with children, but it was all about providing success and also an opportunity for each other to help others. So I have a quote here that I love. The goal of the Montessori program is to support older adults and people living with dementia by creating an environment filled with cues and memory supports that enable individuals to care for themselves, others, and their community. We strive to treat individuals with respect and dignity and honor their choices so that they may live as independently as possible. Okay? So there's been some great research out there, and there's a whole new program that was brought up. It's called the Montessori approach to dementia care. And those that participated in these, they showed an increased active engagement and did not find tasks to be as difficult. If you do something that you succeed in, do you want to repeat it versus something that you do and you don't do so well? That's the whole goal, okay? So we have for you a video, if I can get this to work. That's just what. Oh no. And of course my sound's not gonna work. Okay. I believe, yes. I apologize. All right, well, we'll skip right over this, but please go to the internet and take a look at some of the wonderful videos that are out there about the Montessori approach, because they truly demonstrate how it's important to provide choice and success and things that are important to that individual. So I really wish you could see this. I apologize. So the specific evidence-based programs that we're going to be bringing to Rhode Island through CareLink. First one is called Skills to Care. And Skills to Care is a home-based intervention that helps you as a caregiver provide services for your loved one and dealing with some of the behavioral responses that you may see that are evident in dementia. Okay. So what we will do is we'll come in, meet with you, do a home safety assessment, find out what's important to you. What are some of the things that your loved one is doing that is really difficult for you to manage or really difficult for them to perform? And we'll help you problem solve and analyze the whole activity and make it so that you can then perform those tasks with that individual with much less of an issue with the behavioral responses. That's a quick summary. Some of the things that we'll do too is also environmental modifications. And what evidence has shown with the skills to care, it's demonstrated that improved quality of life for the care partners, improved quality of life for the individuals living with dementia, improved independence, declines in reduced declines in self-care, dependency, and those behavioral responses. The second program we're going to be bringing to you is called Cognitive Stimulation Therapy, or we're going to be affectionately referring to it as CareLink Connects. What this is a social gathering, and this actually is a system that is prescribed by the doctors in the UK to people that are diagnosed, and they have demonstrated improved quality of life, improved function, and even improved cognition. So we're really, really excited to be able to bring these social gatherings together. They're very structured, and what they'll be doing is 2 times a week for 14 weeks. We'll be meeting with individuals and creating these social bonds with other people and recognizing that they have things that they can succeed at. This is a picture of a typical cognitive stimulation group that also includes teaching the loved ones how to carry this out on at home on their own time. And the evidence has shown that with cognitive stimulation therapy, the benefit of memory and thinking skills for most people with mild to moderate dementia. Okay, improvement in quality of life, as I mentioned, and improved language skills and willingness to participate. I'm sure that's something that you've seen more difficult for your loved ones, that they're not as willing to participate. But again, why would you want to participate if you're going to fail? So it's all about making it a successful opportunity. So, in summary, as I mentioned before, yes, we can treat dementia, okay? With rehab services, we can bring in the integral services that are needed that include evaluation and treatment and education for the individuals living with the disease as well as their care partners. Standardized assessments allow us to get a real comprehensive picture of what a person's cognitive function is and what those remaining skills are, and we build on those. Always relate it to functional tasks and relate to cognition, communication, and independence. Always helping the person drive that person-centered care and treatment approaches. And finally, remediation and compensatory strategies that we learn through this whole process are what helps the caregiver as well as the individual living with the disease. So, thank you so much. I'll open it up to questions because I know we were really close on time or I ran over.
We've done well, it's 2:07.
Oh, yes.
How will people get signed up for this program?
Come see us at our table. CareLink has a table. You can also reach out to me. This is my email address, as well as our website. There's information on our website at carelinkri.org that talks about the programs. These programs are going to be free of charge because it is a grant. We're going to be tapping into that grant, and eventually we're actually going to be working on getting this billed to insurance. So we want to make this sustainable so that we can then carry it on beyond the life of the grant.
And will that have, like, what the criteria is?
The criteria is you and me talking. Yes?
Laurie, I have a question. Where the cognitive stimulation therapy Where does that take place?
That's been the fun part in this planning, especially with COVID. So there are two forms of cognitive stimulation therapy. There's the group form, and there's an individual form, okay? So when we were dealing with the high levels of COVID, we were purely looking at individual therapy, and that would happen in your home. But we're really excited to be able to bring in the group piece because that truly interacts the social engagement that's necessary. So we are talking to senior centers and libraries and different organizations throughout Rhode Island. We'll be serving the entire state of Rhode Island and setting those groups up. As I mentioned, it's 14 weeks, twice a week for a complete round. I've been told from other people that have participated, they don't want to leave. They want to keep on doing it. Question?
Does it have to be an OT that does it, or can an OT train other staff?
So for skills to care is the first one that talks about the behavioral responses and helping the care partner learning to problem solve as to what's causing some of those responses. That's definitely just an occupational therapist. That's specifically designed and approved by OTs that are trained in skills to care. The cognitive stimulation therapy, actually, we have our speech therapists and our OTs that are going to be doing it. We're also going to be bringing in some other professionals as we get into the latter part of the grant. But it does not require a specific degree in which to do it. So we're hoping that we'll also be able to get social workers involved and other people so that we can really make it a big program throughout the state.
Is there a minimum number of individuals that you need to have for the group component?
Well, for group two.
Just two. Well, I wasn't thinking, did you have to have 5 in order to do it?
We're hoping to have a minimum of 4, but no more than 10. Yes.
What about the appropriate time for somebody to enroll in a program like that? Like initial mild, moderate?
Well, that's one of the things that we hope we're going to be helping you with, because by coming in and doing home safety assessments, doing initial evaluations with our clinicians, we can help you understand where your loved one is in the disease process. We can help stage that and give you an idea as to what are the things that are easy for them to do and what are the things that are not so easy for them to do. And then we'll look at that. But it's definitely the mild to moderate. The people that are more advanced, it's much more difficult. And and the evidence has proven the mild to moderate stages do really well with these programs. We're real excited. We're hoping to get the final go tomorrow. But we're taking names tomorrow at 11. Everybody, say your prayers. We're just waiting for the ACL to give us a final approval on all of our evaluation and work plans, and then we can start doing the intervention. But the one way that you're helping us today is by doing the demographics and by doing the pre and post test. So if you could please, if you didn't get that, please raise your hand and we'll make sure that you get a copy of those. The demographics helps us to show who we're training and who we're showing how to use these programs. And then the pre and post test shows whether you learned something or not. Hopefully we did our job. Yes? Not off the top of my head. It's amazing. It's amazing how much you can find on Pinterest.
And Pinterest, okay, all right,
Yep.
very good.
You look up dementia care under Pinterest, and there are tons of activities and resources. Yep. Yes.
If we put our name down on the list
Yes.
out there, how soon would we expect to hear from you?
Depends on how fast I can get. I got it.
I don't have a hard of hearing in the home, so.
I'll start making phone calls tomorrow.
Okay, fantastic.
I hope you are as excited as we are as an OT that's been in this field for as long as I have, I've been saying we can treat this, and now we have the evidence to prove that we can. So adopting those healthy lifestyle choices, no matter where you are in the disease process, and even before, it's so crucial that we set people up for success. So thank you so much.
Thank you very much, both of you.
Absolutely.
I did want to clarify in the top right-hand corner of that evaluation sheet where it says participant intake, that's you. It's a multi-purpose form.
You do not have to put your name on it, but if you could please put your zip code on it, because we have to give all this data to the feds.
All right, we're going to have a short break where you can visit the vendors. I believe there might be some coffee out there and other fabulous things. Make sure if you need CEUs that you have signed up in the back on the table. Annie will be sending out evaluations. I believe it is May 5th that she's going to email those out, so make sure your email address is correct in order to get your CEU credits. It's helpful if you let people know which email is which. Okay, as long as Annie can figure out if the name should match up, and you might want to shoot her an email just to clarify that. But enjoy, yes? Yes, yes, 2:30 sharp. We're going to try to get back onto the right schedule, so it's going to be a short break, like 15 minutes, and then we'll be right back here. Thank you, everyone.